Hello, I am Dr. Janice Williams, and this lecture that you will be hearing today is about clinical reasoning, assessment, and planning. This lecture is aimed at advanced practice clinicians who are taking an advanced health assessment course. In this lecture, we're going to talk about the process of clinical reasoning. Let's start by first talking about how you, the clinician, need to identify any of the abnormal findings from your health assessment that you did on your patient. These abnormal findings can be acquired or understood by doing your assessment on your patient. It's looking at both the subjective and objective data that you've collected during your interview and interaction with your patient. Remember, your subjective data is more the story. It's what the patient tells you. Whereas the objective data, it's more of the labs, the diagnostics, and your physical findings. You then want to take that information that you receive from your patient, the abnormal findings, and then localize that anatomically. That means when the patients come in, if they talk about a runny nose and congestion, you want to be looking in the HEENT systems. If they come in with diarrhea and constipation, you may want to be looking in the GI system or the GU system. So that will help you to improve on your critical thinking. If they're coming in with GI symptoms, you don't necessarily want to be doing a MSK evaluation on the patient. Third, what you want to do is be able to interpret those findings. That's when you want to consider what is the pathological processes that may be occurring or are occurring that is contributing to the signs and symptoms that your patient is presenting with. And then once you've done that, you want to then formulate your hypothesis. So you've collected your data, both subjective and objective. You have categorized that objective and subjective data to a anatomical system. And next, you're going to take that and then say, what would be the pathological process? Once you do those three steps, you can then now formulate a hypothesis, also referred to as your assessment. This is where you're making your diagnoses. And although you make a diagnosis, you also should always consider what we call differential diagnoses. This is when you say there is one diagnosis that is the most probable, but there are two or three other diagnoses that may be a possibility. And if they are a possibility, I am going to ensure that I rule them in or rule them out with either my physical exam, my diagnostics, or my labs to ensure that I am treating the patient appropriately and correctly. So let's talk about the steps in this decision-making process. 1, select the most specific and critical findings support your hypotheses. That's your subjective, objective data. Match your findings against all the conditions you know that can produce the same findings. That's your differentials. Then you want to eliminate the diagnostic possibilities that fail to explain the findings. And then you want to weigh the competing possibilities and select the most likely diagnoses. Be sure to give special attention to the potentially life-threatening treatable conditions. I call those the red flags. Those are the things you don't want to miss. If you miss a life-threatening, a red flag, it can be detrimental to your patient. So you want to make sure that you're always considering those as well. So let's try to test this hypothesis out, right? You have a patient that presents, and the patient is complaining of stomach pain. You talk to your patient and they recognize that the pain begins after eating food. It worsens when they have an empty stomach. They do not have any diarrhea, but they do have nausea. They have tried taking Tums and get a little relief, but not much. Patient also states to you that the symptoms intensify when they lay down. They do not have any numbness or tingling in their right or left arm. They do not have any blood in their stool. They do not have any urinary complaints at this time. They don't have any headaches, and they don't have any dizziness. They do report to you that they drink alcohol, possibly 3 days a week. They drink about 2 to 3 glasses of wine or 1 to 2 cups of liquor. They like spicy foods. They eat out quite a bit. They eat fried foods. So they eat whatever diet they choose. They're not really on a specific diet. I want you to take a minute, stop this lecture, and think about I want you to go through those steps. What were the signs and symptoms that you heard? What is some of the subjective and objective information that you have or that you would need to be able to figure out what to do? When you think about the symptoms that was presented to you, anatomically, what area of the body would you be focusing on? Then when you think about it, pathologically, what could be causing the symptoms that your patient is discussing with you? And then finally, I want you to come up with a hypothesis and then some differentials. So now, let's talk about how you develop a plan that is agreeable to your client, to your patient. Remember, healthcare is not a paternalistic system. It is a collaborative system. We have advanced knowledge that we share with our patients, and then we collaborate with them to develop a plan that is both agreeable to the patient and to ourselves. So what are some of the challenges you may face when trying to collect your data so that you can go through your clinical reasoning process? One is having multiple problems that your patient may present with, or problems that can cross different anatomical systems, and you're not sure, is it a heart issue or is it a GI issue? Learning how to tease out and separate what you see and what the patient is saying can sometimes take time. And you need to ask key questions that will help steer your thinking. If you just ask questions without having a purpose behind the question, you're going to come up with more information than you know what to do with. And if you run labs and diagnostics without a clear focus on what the reasoning behind ordering that lab, then it can make you even more confused when the results come back. So how do we assess the information that we have when we think about the clinical data that we get? I'm going to take you back a little bit to your research that you've had in previous schooling. Terms that are very important. Knowing the difference between reliability, validity, sensitivity, specificity, and predictive value. Reliability is when we measure how well repeated measurements of the same phenomenon will give the same results. Is it going to be replicated over and over again if it's the same phenomenon, the same situation? Validity it indicates how precise a given observation agrees with the true set of circumstances. How valid is it? How does what you see, how often does it really agree? So how often does what a patient may say, the symptoms that they may present with, what you see with the patient, how often does that symptom go with a specific diagnosis? When we talk about sensitivity, it identifies the proportion of people who test positive in a group who are actually positive. So when they are actually positive, they test positive in a group. Howeas specificity it identifies the proportion of people that test negative in a group that actually have it. And then we also have our predictive value. It indicates how well a given symptom or sign predicts the presence or absence of a disease? How well can it predict? So how do we integrate the clinical reasoning and assessment of clinical data? Let's do a case study. A 38-year-old female comes in. Something hit me in the right eye when I was hammering a nail in a wooden board about 3 hours ago. Past medical history is astigmatism. No known allergies. Identify the abnormal findings. Localize the findings anatomically. Interpret those findings. Test your hypothesis. Establish a working diagnosis. Develop your plan of care. Every time you're going to go through that with every concern that your patient may present with. And here, what do you see up here? You see a little piece of wood. So your diagnosis probably would be a foreign object in the eye. But you still had to rule out other things because your patient had some other history, right? So you collected the information. You thought about it anatomically. What part of the body would I be looking at? The eye. Then you thought about pathology. What would that cause? What would be the pathological processes behind that? Then you have to think, I've collected the data, I've done all that. Now, what would be my hypothesis and how do I test it? And what are your differentials? What other differentials could you have had? Here's another case study. 34-year-old woman who presents with 5 days of dysuria and malaise and has some back pain today. She denies fever, chills, nausea, and vomiting. On examination, she is in no acute distress and has the following vital signs. She has moderate right flank tenderness on percussion and no abdominal tenderness. What other data from the history and physical do you need to properly diagnose and manage this patient? Take a minute, stop this lecture, and think about it. What else would you need? What other information would help you? Then you want to make sure you organize your patient record. This goes back again to what we talked about related to the SOAP note. Subjective, objective, assessment and plan, right? Now let's go one more case study. If you see the picture here, you see the rash on the right side of the patient's neck behind their ear. And the patient comes to you with their chief complaint. I have an itchy round patch on my neck. It appeared 1 week ago. What is it? Your microscopic exam with KOH reveals multiple hyphae. So what helps you in this case? One, you want to go through that process. What are the signs and symptoms? What is the subjective and objective data that you have with this patient? Anatomically, where are we going to be focused on? Pathologically, what could be causing this problem? That brings your anatomy and physiology back to you. Then you want to come up with your hypothesis. You look at your diagnostics, you look at everything, and then you come up with what would you think your assessment should be for this patient and what would be your plan. I want you to go back and listen to the lecture or review in your mind what we talked about when we talked about the SOAP note and all the components of the SOAP note. When you think about your plan, what are the 5 things you would think about with this patient? What are the 5 areas that you need to address with them? Remember, non-pharmacological, pharmacological. It's educational. It's referrals or diagnostics, right? You have to go through those steps. That concludes this lecture on clinical reasoning. I want you to take time to recognize systematic process helps you to be able to practice safely and provide your patients with the best care. It takes time to learn the systematic process, but be systematic in how you evaluate and assess your patients. Start off having a good foundation on how you systematically collect your information for your health assessment on your patient. That's your detailed SOAP note. That's when we talked about the chief complaint, the HPI, the social history, the medical history, the allergies. You talked about the family history. We talked about the their environment. We talk about their diet. We talked about their immunizations. We talked about the review of systems. We talked about their maintenance. All of those components that go into your SOP, SOAP is going to be very important now to help you in your clinical reasoning. They're two separate entities, but they work together. They are synergistic with each other. So take time to really understand and hone on those skills. And as you go through your journey, collecting more information, learning more pathology, learning more about the different diverse clinical diagnoses and disease processes, but remembering to always go back to your basics with your health assessment and then your clinical reasoning. There is also a textbook I would like to leave at the end of this lecture just for you to think about reviewing. It's called Advanced Health Assessment and Clinical Diagnosis in Primary Care. I think I have the 6th edition. There may be a later edition, I'm not sure. And it is by Daines, Bauman, and Schiebel. It's a very good resource for you with clinical reasoning. Okay, and I look forward to talking with you in the next lecture.